So look, it's nice to meet you. My name is James. I'm a colorectal consultant, and I'm a reader and surgeon at Imperial College in London. And in the next sort of 20 minutes, what I'm going to try and do is give you a very broad overview to the anatomy of the rectum and common conditions that you might see, so that you're familiar with them. What I'm not trying to do is to make you an expert in the diagnosis and management of these conditions. All right. So this is a very broad, general introduction to make you feel more confident if you come into contact with these things during your examination, but also to give you a structure as to what to look for. So just to start with the kind of basic anatomy, obviously the rectum is a tube, and the objective of Illumini investigation is to properly inspect the full length of this tube up to what we call the rectosigmoid junction. So that's the moment where the rectum becomes a sigmoid, which is actually surprisingly hard to define, and colorectal surgeons spend a lot of time arguing about it. But broadly speaking, it's about 15 centimeters usually away, 13 to 15 centimeters away from the anal margin, and it's usually at the point where the peritoneal reflection sits, and you get mobility into the sigmoid. And actually, the more luminize you do, it becomes quite easy to see, and you can kind of know when you're there. So the peritoneal reflection importantly covers the kind of the upper half of the rectum, and you'll probably know a little bit about anal anatomy, but when you put a camera in through the bottom, typically you'll see these sort of you'll see these little valves along the bottom, and they're usually about 2 to 3 centimeters inside the anus, and that typically represents the dentate line, and that separates the rectum from the anal canal. That's actually quite important for a number of different reasons. Pathologically, it's important, but it's also important because nerves come from outside in. Basically, sensory nerves come from outside in. So you have lots of sensation up to the dentate line, but after the dentate line, it's painless, which is why when we apply therapy for hemorrhoids, we always apply that therapy above the dentate line. The anal canal is lined by a different type of epithelium to the rectal canal. So the anal canal is squamous, and it has a very rich and vascular nerve supply. And you can see as well, you've got the location there of the internal hemorrhoids, just above the dentate line here, where these little valves are. So a hemorrhoid is something called an anal cushion. An anal cushion has within it, yes, it has blood vessels, rather obviously. So, but it also has connective tissue, and often a rich supply of nerves, which is why they're so painful when they go wrong. And actually, an anal cushion's job is to maintain continence because it's kind of nice and squashy, but it's also it probably has a sensory function. So it's part of the defecatory reflex that tells the brain that it's time to go to the toilet. So once you get through the anal canal and you hit the dentate line, you'll see you'll get into the kind of rectum proper, and in the rectum proper, what you'll see is these 3 kind of folds in the rectum called haustral folds, or valves of Houston. I say Houston as if I was from Texas, and they're usually around 5, 8, and 11 centimeters. And these are really important to identify when you're doing your lumini examination, not least of all because you've got to navigate around them. You've sort of got to wiggle around them. But more importantly, you want to be able to visualize both sides of the haustral fold because you have a little polyp sat here and you're not properly looking, you'll miss it. But there's anatomical importance because if you know you've got 1, 2, 3 valves, you know then the next stop should be the rectosigmoid junction. So good lumini practice is to be able to visualize those 3 folds as you go through. If you just want to ask me questions at any time, please just ask me questions. What we know is that there's a sort of angulation of the rectum as it meets the anus, and that's because, of course, from an evolutionary perspective, we're designed to walk on all fours, and then at some point we stood up, and that sort of created this angulation, and that's important when you're performing your lumini because you need to change the angle of the lumini after you've inserted it, usually for about 3 to 4 centimeters once you've got through the anal canal. So what I tend to do is, I'm going to start by really sort of inserting the lumina a little bit anteriorly, so my hand away from me. And once I've got through the anal canal, I'm going to bring my hand towards me and get around that corner so I can get more safely into the rectum. And the nice thing about the Lumina is, of course, you can see this whilst you're doing it. You can't see that with other kind of devices. So hopefully that gives you a bit more confidence. Now, before you put your Lumini in, what you're going to do is you're going to have a look at the bottom. So, all good examination starts with inspection. And actually need to be quite careful when you are inspecting, because some of these things that you're looking for can be quite nuanced and quite subtle. So, for example, this is an anal fissure. An anal fissure is a chronic ulcer that's formed in the anal mucosa, and typically it forms through trauma. And you can see at the base of that anal fissure some white fibers there, which are the fibers of the internal sphincter. Sorry, it's really loud drilling here. And these can be exquisitely painful is the main thing. So typically the main story with anal fissures is that they're painful. And therefore, if you've got a lot of pain when you start your examination, they're saying, ow, don't keep going, just stop. If you see an anal fissure, you don't need to complete the examination. You can make your diagnosis, you treat the anal fissure, or you ask a clinician to help you treat the anal fissure, and then you come back and you perform the Lumini once it's healed and they're well. So the main symptoms of that you're really interested in is the symptom of pain, and it's typically the most important thing to be aware of is that it's really, really painful. So patients will describe it as like pooing glass. So it's pain, pain, and pain. They might have frank bleeding. They might have noticed a tearing sensation, and usually they've been sort of chronic and remitting. So they come and they go. They come and they go. So the most important thing is that you ask, you take a good history, and you'll see what what those images have just shown. So they're typically superficial and well demarcated. Just note that sometimes they hide behind a little polyp. So you can have something called a sentinel pile, which is actually just a kind of piled up fibrous tissue, which looks a bit like a skin tag. So if you've got a skin tag on the bum, you've really got to look quite closely, because the anal fissure might just be hidden within it. So if you've got pain, two things typically cause severe and intense pain in the bum. Well, in a literal sense. The first is anal fissures, and the second is thrombosed hemorrhoids. So hemorrhoids that are thrombosed means that effectively there's a clot inside the capsule of the hemorrhoid, and you get tension. It's exquisitely painful, but it's usually very obvious. You'll see a big sort of usually a bluish, hard swelling on the anal margin, and you'll know straight away what it is. Again, if you see that, don't keep going with the Lumini. Just be aware of kind of other weird and wonderful things when you're examining the bum. So always have in the back of your mind inflammatory bowel disease. Always have in the back of your mind kind of sexually transmitted problems like HIV or even syphilis. And of course, we're always thinking about cancer. If you've got an anal fissure, typically the main thing is to get these patients off the loo. So they need lots and lots of stool softeners. They need good education to be told to avoid straining, and they need nutrition and dietary information. And actually, in young women, particularly, well, not young women, but in women more broadly, I often get them to see a pelvic floor physiotherapist. That often helps. They need lots of good analgesia, avoid opiates because they constipate, of course. And the main thing is that we typically give them a sort of topical agent like rectogesic cream, which is a GTN ointment that causes vasodilation and improves perfusion. The challenge with rectogesic is that it often causes headaches, and patients need to be warned about this. Typically, they will get resistance to that. I'm just giving a lecture. So the the main thing is that these things are managed, with a clinician helping you. What we sometimes do, if the rectogesic doesn't work, is we can escalate that to diltiazem, and in the worst cases, what we can also do is we can inject Botox. So that's something that again is typically done under general anaesthetic, and it's done by a surgeon. I think the main thing with all of these treatments is they've got a high failure rate. So about 60% of patients will get better with rectogesic, and they need to understand that will take about 6 weeks. So they've really got to keep going with the ointment, or it won't get better. And the main thing is just get them off the loo and stop them straining. So hemorrhoids are what I've described to you previously. They're a dilated anal cushion. And typically, patients will have a history that is, either asymptomatic. So many patients, well, I mean, hemorrhoids are just normal part of anatomy in many senses. So many patients are asymptomatic, but either they'll complain of bleeding, which is usually frank, or occasionally they'll feel a lump around the bottom, or they might have itching or discomfort. These hemorrhoids we grade, and I'll come on to that in a second, but either they're going to be external, so in prolapse, or they're going to be internal, and you'll see them when you do the lumini, or you might have a combination of both. Typically, we talk about grading. So we have 4 grades. So one is that they're internal, and you won't see anything on your external examination. I have to say, I've almost abandoned proctoscopy in my clinical practice, and I just do the lumini anyway, because with the lumini, you get such a good view of the anal canal when you put it in. I almost never do proctoscopy, and you can nearly always see the internal hemorrhoids. Grade 2, they prolapse, but they go back in, so they'll come in and out. Typically, patients will describe straining, and that they will pop back in on their own. Third, they're sort of permanently prolapsed, and quite often patients will describe pushing them in. And 4th degree typically are complicated. So either they've got some degree of prolapse that is led to a thrombosis or pain. They never go back in or out. They can't push them back in, and they're usually needing a definitive surgical strategy to fix them. The symptoms I've kind of already told you about. Again, treatment is largely conservative. The way I think about hemorrhoids is if you've got hemorrhoids, probably that's a biomarker for poor gut health. And actually patients at that point need a lot of education on nutrition, diet, and improving their gut health more broadly. So it's everything from exercise to defecatory toilet habits. So they need to be told, again, not to strain or to push. It's usually men need to be told to not read on the toilet or use their mobile phones on the toilet, and they need to be in and out and off the loo in 2 minutes. And usually with proper stool softeners and correction of constipation and toilet habits, these will usually be temporary symptoms, and they'll get better. But occasionally we do have to do something more interventional, like put a band on the hemorrhoid, or occasionally inject them, and rarely surgery. Abscesses are a common thing that you might see before you've even put the lumini in. And again, this is another thing that can cause pain. So if you've got pain with redness, swelling, or purulent discharge, think abscess, think infection. Again, you don't then need to really proceed. Typically, abscesses form when anal glands, which just sit at the bottom of those crypts that I pointed you out at the beginning, become blocked. They develop an abscess because bacteria can't discharge out, and that becomes very painful. And then it can sometimes lead to a fistula. This is something called the cryptogenic theory of fistulation. So those abscesses are really very corrosive. So the pus discharges through the route of minimal resistance, and it will discharge both in and out of the bottom, causing symptoms. It's a bit of a blurry photograph, apologies, but this is what a fistula looks like. So you'll typically see a dot, usually far away from the anal margin, and this patient will often describe of symptoms of purulent discharge, occasional bleeding, and discomfort, and it's usually pretty obvious when you see it. This is an abscess. You can see this is a bit different. You've got a pointing abscess there. That's a bit of pus. That will be agony. And again, if you're seeing that, you don't need to, do a lumini. You need to stop and get a surgical opinion, because they need drainage. Obviously, we're worried about cancer. So now, by the time you've got the camera inside the bottom and you're having a look, what you're principally looking for is either, of course, a cancer, but also a precursor lesion of cancer, which is called a polyp. So a polyp can be a benign growth, effectively, and they come in lots of different subtypes. And we'll talk about that in a second. But the kind of standard theory is that these polyps go through a series of genetic mutations that ultimately at some point leads to adenocarcinoma within the polyp, which then becomes invasive. So what we're trying to do with lumini is identify polyps, because if you can identify a polyp, you can prevent cancer. And if you're identifying polyps, of course, through lumini, and you've got them in the rectum, then patients will need proper colonoscopy to make sure they haven't got polyps elsewhere in the colon. So actually your ability to detect them is quite important for these patients. Now, sometimes it can be really easy, and sometimes it can be a bit trickier. So what type of polyps are there? Well, so the common polyps that you'll see in the bum are what we call fibroepithelial polyps. So you'll remember that I said that there are different types of cells that line the anus and the rectum. So these typically come from cells that line the anus or the skin, and it's all in the name. It's epithelial, right? And these typically look white, quite fleshy. They're usually stalked. and they're extremely common, and you'll see them a lot when you start to do examinations. And basically, they can be left well alone. They're not going to become malignant. They're not the type of polyps that progresses in the picture I've just shown you, and most of the time we don't need to do anything for them. If they become really symptomatic, we can fish them out. Hyperplastic polyps are also quite common. So polyps form basically according to 2 or 3 different genetic pathways, if you like, and the hyperplastic polyps are, form along something called the serrated pathway. And historically, we've thought about them as having a low risk for bowel cancer, but our understanding of that is slowly changing, and we're beginning to change our guidance for what we do with these. But anyway, what we recommend, if you see any polyp at all, don't worry, just refer. They need colonoscopy, and typically we can remove them with an endoscopic mucosal resection. So you can see in that picture, an endoscopist is about to use a snare to remove them. If you see them, you don't need to biopsy them. This is a bit more worrying. So this is something called a tubulovillous adenoma. So villous adenomas are what we call sessile growth. So it means that they're kind of like carpeted, right? And typically they have cells which are beginning to undergo changes on the pathway towards cancer, and the word for that is dysplasia. And the larger those polyps, the higher the risk that either they harbor a bit of cancer within them, or that they're going to become cancer in the future. So again, if you're seeing anything like this, what you want to do is take a photograph, document it, describe it, and seek a second opinion. The patient needs a formal colonoscopy and then endoluminal treatment. What we tend not to do is biopsy these, and the reason we don't biopsy them is if you biopsy it, it can compromise the ability to come back and do a more formal endoluminal resection. So don't feel like you are compelled to biopsy it. What you want is an expert endoscopist to come back and have a go at removing it on block. And when you remove it on block, you get a more definitive histological perception. Note that some of these can be pretty subtle, right? So actually, you've got to have your wits about you. You can see here you've got a polyp just on a fold, and you need to be looking quite closely. They're not all sort of fronded and obvious like this. And so actually the withdrawal time that you have when you're performing a rectoscopy is very, very important. You should be spending at least a couple of minutes withdrawing that scope and having a really good look around so you don't miss them. And again, look, again, with the eye of faith, these flat polyps can be really quite subtle and hard to detect. So you might just be able to see my mouse there outlining a sessile serrated adenoma. So sessile serrated adenomas are also kind of thought to be pre-malignant, and again, they need referral for full colonoscopy. And when that colonoscopy happens, they need dye spray and proper inspection. I don't think you need to know this in your reporting of your polyps, but I think it is important that you use the right terminology when you describe them. If you go into any endoscopy suite, they'll have a Paris classification system up on the wall, and the Paris classification typically describes the shape and morphology of the polyp. So broadly, they can be flat, they can be sessile, or they can be pedunculated. So pedunculated means they've got a stalk. Sessile means they're sort of bulging, but they don't have a clear stalk. So they're kind of protruding, if you like, from the lining of the mucosa. And flat, well, they're flat. And you can see that we have these different terms. So we have IP for pedunculated, ISP for subpedunculated, and IS for sessile. And then we sort of we grade them depending on the elevation that you can see, and then also the depression and the degree of excavation. So you'll often hear, for example, you'll have an IP polyp. You might have a 2A polyp, for example, that's flat. This is what a cancer looks like, and it's kind of obvious when you see it. What makes this a cancer is that it's got an ulcerated center there, and it's got this big rolled edge, and that is really a hallmark of a malignancy, and it looks very nasty. You can see the same sort of thing here. I think if you're comfortable and you're trained to do biopsying, this does help if you can biopsy the patient at that time, because it will increase their progression through the cancer pathway. Obviously, those patients need referral. Other things that you might commonly see that cause bleeding or discomfort, you might see something called a rectal ulcer, and there's a condition called solitary rectal ulcer syndrome. So these are kind of, they're not that rare, actually. I think we see them relatively more frequently than we used to think. But typically it happens in patients who've got chronic constipation. It's probably a pressure effect. So either it's the mucosa intussuscepting on itself, or it's a pressure effect of feces. But you'll see what looks like that. It's sort of a flat ulcerated lesion which will bleed. You're obviously on the lookout for inflammation, and proctitis is a nondescriptive term for inflammation in the rectum that can obviously be caused by a number of different factors. So it might be a bacterial infection or a viral infection or parasitic infection, or it could be an underlying autoimmune pathology like inflammatory bowel disease, such as Crohn's, or more likely ulcerative colitis, or quite commonly it's caused by iatrogenic factors like radiation therapy or diversion proctitis. So if anybody's got a stoma, we quite often see inflammation. You'll know because it's friable, it's delicate, it's bleeding. And again, if you see this, take a video, take an image and record it, and the patient needs referral. I mentioned at the beginning that you're going to keep an eye out for other benign conditions that are important not to miss. And again, when you're looking at the bum, just keep an eye out for warts. They happen in people of all sexual persuasions and all ages, and they can be both internal on the skin.
So sorry, James. Just Rivia had a question just about the last slide.
Oh, sure. Yeah, go for it.
Hi, James. Regarding the rectal ulcer, you said that it's due to constipation, the pressure.
Yeah.
Do you do something about it?
So you don't have to do anything about the ulcer itself. You can leave that and it will get better. But what you need to do is to treat the underlying cause. So they need help and management in managing their constipation. And the management of constipation is probably a lecture in its own right. But very simply, that means doing simple nutrition and dietary things to improve the chemistry of feces, or the kind of physiology of feces. So that means making sure they have enough fiber in their diet. So they need to be told to have 30 grams of fiber a day, to eat mixed fibers. And they also need to have enough hydration. So they've got to drink enough in the day. So that means 2 liters of fluid a day. They might need stool softeners, or they might need some motility agents to help with that. And if simple things are not helping their constipation, then they might need referral to a specialist, because they might have pelvic floor dysfunction or some other mechanical cause that's exacerbating it if they've got an ulcer. Does that answer your question?
Okay, thank you. Yes, thank you. Thank you.
Okay, cool. So again, if you're seeing anything like this, I mean, it's not rocket science. It looks awful, isn't it? It looks really awful, in fact. And that your concern there is that this is a squamous cell carcinoma, and that's something that you need to refer, because that might be a cancer. Again, here looks pretty awful, doesn't it? It's very obviously something wrong. I think if you're seeing this, you don't need to proceed with your Illumini investigation. You can just refer that immediately on a cancer 2-week wait pathway. So look, that's a super fast whistle-stop tour of the anorectum and the common things that you're likely to see or that you want to look out for during your examination. Is there anything you'd like to ask about any of that?
Hi, James. So the anal fissure and the anal abscess. Oh, the abscess, yes, you can define. But the anal ulcer, there's a little bit, it's similar.
Sorry, are they?
The anal fissure.
Yeah.
And the other ulceration, it looks very similar. Do you sometimes make mistake of identifying any of those?
Well, I think they can be difficult to identify, but so usually taking the history is so important, because a lot of it will come from the history. I think what you might mean is an anal fistula rather than an anal fissure. So an anal fissure is this. It's this kind of tear. It's always on the anal mucosa. It's sometimes hidden behind a little tag. You can see a little tag there. You'll see a little white base where you can see the fibers of the muscle underneath it, and it's exquisitely painful. So that, I think, is really quite discreet and quite different. So an abscess is is different because number one,
it's a fistula. Sorry,
yeah, fine, yeah, okay. So yeah, you're right. Fistulas and abscesses are very commonly missed, and the reason that they're missed most of the time is that people aren't thinking about them. So if you're seeing this, so this picture shows a couple of key things. Number one is that this is red and angry, right? This side compared to this side, God gave us, you know, two of most things, so you can compare them. This is red and it's got cellulitis, which means that there's active inflammation and infection, and you can see pus. You can also see that this is swollen. So when you see that, to me, that means there is pus underneath that skin, there is active infection, and that needs acute surgical management. Now, it might be that there is already a fistula there, it just hasn't manifested itself yet, but that is an acute abscess. This, sorry, it's a terrible photo, is a fistula, which is very different. So here, there's no cellulitis, there's no infection, there's no pus, there's no redness, and the external tract is quite somewhere away from the anal margin. So you might think that this is an anal perianal abscess, but I think, yeah, it's definitely got a discrete set of presenting features. So I would say, look, you know, don't worry if you make a mistake. That's okay. All that matters is that you're thinking about it, and if you've got something that you're not sure about, that you refer it on and you get another opinion on it.